Want me to turn the volume on? Yeah, turn it on. Yes. Yeah, please do turn it on because I don't have earbuds today.
Hey everyone, welcome to the ATC Recap Webinar. This is Jamie Benken. We're going to give a few minutes for people to continue logging in, get connected. Again, this is Jamie Benken. If you can direct message me with any questions you have during the talk, and we'll cover them during the Q&A at the end. Hey everyone, I think we'll go ahead and get started. Welcome to the ATC Recap Webinar for 2023 on behalf of the ACCP Immunology and Transplant CRN and the Programming Committee. Welcome to our 8th webinar of 2023. My name is Jamie Benken from University of Illinois Chicago, UI Health, and it's my pleasure to moderate today's ATC Recap Webinar. We're honored to have Lauren Schumacher and Kaitlyn Legg serve as our webinar presenters today. Dr. Lauren Schumacher will be presenting first, and she received her PharmD at the University of Michigan in 2018, followed by a 201 pharmacy counselor's residency at Benken Medical Center and a PGY2 in transplant at University of Michigan. Upon completion of residency training, she has joined the transplant team at University of Kentucky as adult abdominal transplant pharmacist. She provides pharmacy support to abdominal transplant recipients in inpatient and ambulatory settings. She's an active member of the ASP and the ACCP PRN, currently serving as the chair of the podcast committee. Our second speaker, Dr. Kaitlyn Legg, studied at the West Virginia University School of Pharmacy, where she received her PharmD in 2021, then completed PGY1 at University of Illinois Chicago and her PGY2 in transplant at University of Maryland. She's staying on after completing residency this year with the Maryland team as one of their 9 transplant pharmacists who rotate amongst all organs, providing both inpatient and outpatient solutions. So in a moment, we'll get started with our webinar. So here are a few quick notes. Audience members, please ensure that your microphone remains muted for the duration of today's presentation. The mute button is in your lower left hand corner of your screen. If at any point during the presentation you have a question for the speaker, please submit your question using the chat functionality at the bottom of your screen. You can send your questions directly to me, Jamie Benken, the moderator of today's webinar, to minimize possible interruptions. We'll take questions at the completion of the presentation. Today's webinar is being recorded and will be posted on the ACCP IMCR YouTube page. If you experience any technical difficulties during the webinar, please log out, refresh your internet connection, log back in, let me know if that does not work. Now, without further ado, let's begin our webinar with Dr. Schumacher.
Thanks for Thank you for the introduction, Jamie. All right. So, I might have lost remote control. Wait just again. Okay. So we are going to start off with all of the infectious disease topics. So starting off with our favorite virus, CMV. Y'all probably now are aware of this trial. It's since been published in JAMA, but given its relevance, its importance, what it's done for the FDA approval for letermovir, I do want to share it as it was presented by Benken and colleagues. So this here is the phase 3 randomized double-blind non-inferiority trial comparing letermovir with valganciclovir in CMV high-risk kidney transplant recipients. They had about 600 patients randomized and stratified by presence of lymphocyte depleting induction. And they started study intervention by post-op day 7, continued therapy until up to 200 days post-transplant. Now, first looking at the efficacy outcomes, where our primary outcome was CMV disease at 52 weeks. Of note, I thought they did this well. This was all investigator-reported cases of CMV disease that then went through a clinical adjudication committee to assess and confirm by, let's say, biopsy if necessary. They found that CMV disease was similar between both groups, and ultimately they were able to show that letermovir was not inferior to Valcyte. And then at certain set points post-transplant, they got CMV PCRs. So this is how they were able to show CMV DNA at 28 and 52 weeks. And anytime there was a positive PCR, that was then sent out for next generation sequencing to assess viral resistance. So they found no cases of viral resistance among those receiving letermovir versus 5 in the valganciclovir arm, which I think is interesting. Perhaps if they were looking for it, they found it. But I think the winner here, and what really is going to excite all of us, and it excites me for all of the myelosuppressive issues I run into, is the reduction in leukopenia and neutropenia. So significantly less white counts, less than 3,500, and ANC less than 1,000, with those receiving letermovir versus Valcyte. So of course, we got our primary outcome that letermovir was non-inferior for CMV disease in this high-risk population of kidney transplant patients. But the other upsides is that there is less neutropenia, less neutropenia. And while we know that when letermovir is used for treatment, there's a low barrier, a genetic barrier to developing resistance. So we're all concerned when using it for that indication. I think this gives us some comfort when using for prophylaxis that we might not be seeing the same concern. So of course we have FDA approval for this indication now in our kidney transplant patients, but I'd love to see it be expanded to other organs and perhaps being able to use it in intermediate risk for those that can't tolerate valsite and preemptive monitoring isn't appropriate or logistically doable. As I can imagine that not having FDA approval may limit insurance coverage. So switching gears to CMV treatment now. So there are a number of transplant centers that are using maribavir and came forth with their single center maribavir data. I think altogether it tells a very compelling story. So this will be the next few slides I share. So this is out of VCU presented by Sarah Sterling. This was 6 patients, a mix of heart, SPK, and kidney transplant recipients that received maribavir for resistant or refractory CMV. So out of these 6 patients, only 1/3 were able to achieve viral suppression, but notably both had rebound viremia about 5 weeks post maribavir discontinuation. And that means that the other 2/3 did have persistent viremia and had to switch to an alternative agent such as foscarnet. We saw a similar experience out of Duke presented by Dr. Ben that had a larger amount of patients and a greater mix of thoracic and abdominal. And again, maribavir for resistant or refractory with either DNA or CMV disease. This time we have about half achieving viral suppression. Unfortunately, again, we saw 2 out of 6 recurrent DNA after maribavir discontinuation. So 1/3 did have documented virologic failure or relapse that occurred in the setting of resistance and also required switching to an alternative agent. And 3 were not able to be commented on in terms of maribavir treatments or failure, but I did want to point it out. Of course, we are pharmacists, so things such as drug availability is a very real logistical challenge we may face. And then we have this presentation out of NYP. Nick Legg presented this. It was initially given as a poster, but it's since been published as a letter to the editor in clinical transplantation. So this is where I pulled the table from. Their experience was similar to others, is that they noted that there was breakthrough in a number of patients. So they wanted to compare the patients that had breakthrough on maribavir to those that did not and see if there were any characteristics that seemed to predict failure. So ultimately, there were no identifiable differences. They compared transplant type, CMV risk stratification, CMV viral load peak and at baseline, et cetera. But what I thought was really interesting here, of these patients, 4 with breakthrough, 3 had continued on with maribavir 400 twice a day for secondary prophylaxis after either they had finished treatment with maribavir or I think additional one received foscarnet. In these patients, when they had breakthrough viremia, they demonstrated UL97 resistance. And last but not least, this is a group out of MUSC. This was presented by Jessica Newman. They also presented their retrospective case series as well as viral kinetics of maribavir. And they had 17 patients, a mix of abdominal and thoracic. Similar stories as what we've seen elsewhere. 20% achieved cure, 13% maintained low-level viremia with those definitions listed here, while 3 or 20% had confirmed resistance, and that leaves half to have an increased viral load on maribavir, and either resistant testing came back negative or it wasn't sent. They then utilized the CMV PCRs to create lines of best fit and organize that by the outcome and the organ. So I thought this was really interesting data to utilized to kind of have an understanding if patients may not be responding as you might suspect. But I think altogether this tells a very consistent story that while the Solstice trial had pretty good outcomes, that there was about 56% of patients that achieved CMV clearance at week 8. Real-world data of maribavir in our solid organ transplant patients with resistant or refractory CMV seems to have lower treatment success rates. And while this is absolutely a very useful agent, I think we should still be using it for this indication, especially since it's well tolerated. It's an oral medication. It can prevent hospitalizations potentially. I think providers need to be aware of the risk for development of resistance and being cognizant that viral load should be monitored regularly as indicated. And while it's not currently approved for secondary prophylaxis, and this is very much off-label use, I think it's going to be surprising to some that we should be aware of the same risks, specifically for developing resistance and rebound DNA anemia. And last but not least, I think that there's a lot of work being done with maribavir, and there's a great opportunity for multi-center collaboration, specifically being able to predict indicators of treatment failure. So I'd love to see that going forward. All right, and in case y'all aren't sick about talking about CMV yet, we got the CMV T-cell immunity panel. I'm going to abbreviate TCIP. So I got 2 studies here. This first one was out of Piedmont, presented by Alexa Ray, and they were curious if they utilized the T-cell immunity panel in CMV high-risk patients to direct duration of valsite prophylaxis if that changed outcomes. So my understanding is that previously they gave valganciclovir in these patients for 6 months, and as per guidelines, discontinued at that point. But what they changed their guidelines to at Piedmont was this flow chart on the left. So at 6 months, all patients underwent, or this high-risk patients underwent the T-cell immunity panel. And if they showed immunity, valsite was discontinued. If they did not demonstrate immunity, valsite was continued for additional 3 months. And then the T-cell panel was checked again, rinse and repeat. So I don't think this is going to be surprising to many of us. At 6 and 9 months, the number of subjects that demonstrated immunity was low, indicating that what's seen here is there's low T-cell immunity panel at this time point. That meant valsite was continued for 9 to 12 months in these patients, with CMV viremia listed here. What they did note is that the continuation of valsite in this population did seem to lower viremia rates, compared to their historical cohort. But let's take a slightly different look at evaluating the T-cell immunity panel. This was out of University of Wisconsin, and they wanted to evaluate the positive predictive value of T-cell immunity assay to determine freedom from viremia in kidney and pancreas transplant recipients. I will note that majority of these were kidney transplants alone. There was a mix in terms of evaluating it in the setting of CMV treatment or prophylaxis. And not surprisingly, about 2/3 of these patients were CMV high risk. So breaking down their results, first looking at the left, they utilized the numbers from the table here. So positive T-cell immunity, indicating immunity, versus any of the other outcomes that we could see, broken down by prophylaxis and treatment, and then identifying those that develop CMV within 90 days. That resulted in a positive predictive value of 86% of prophylaxis patients, about 79% of treatment patients. They hypothesized that the major place in therapy for this would probably be high risk subgroup. So about those 2/3 of patients found the positive predictive value to be about 66-67% each. So the next question was, out of those patients that demonstrated immunity but developed CMV, what happened? So they commented specifically on 6 individuals that had progressive replication and required antiviral treatment, and noticed a few trends. The first one being that 4 were CMV high risk. Also, 4 had concomitant clinical stressors at the time of recurrence, which include bacterial infection in 2, and then AKI requiring dialysis in another 2. And And then 2 had intensification of immunosuppression between the time of the immunity panel and CMV viremia. So I think we still have a lot of questions about the best way to use the immunity panel, whether for primary prophylaxis, secondary prophylaxis, both. I think there's a lot of areas for future research in terms of if we're adjusting prophylaxis strategies, what are the outcomes, and acknowledging what our outcomes of interest are, weighing risk versus benefits, for example, prolonging Valsite, which is a myelosuppressive and costly therapy for patients. If there's higher rates of viremia, is that worth the cost? Or, for example, are we more curious about CMV disease? So I think the other big takeaway is when interpreting T-cell immunity panel results, it's very much a snapshot in time. So we must consider the clinical context, such as the overall immunosuppressive burden in the patient's probably alloreactivity, and know that this is fluid and it may change over time. So transitioning now to one of our other favorite viruses, BK virus. I was very pleased to see that there's 2 phase 2 studies that were presented at ATC. I won't present them in great detail, but I do want to share it with the group with what's potentially up and coming. So this first phase 2 study looked at a monoclonal antibody called MAU868. It's a novel antibody that works by preventing BK cell surface binding, ultimately preventing cell entry and spread of infection. This was compared to placebo in a group of kidney transplant recipients less than a year post-transplant with documented BK within 10 days prior to enrollment. They did have 2 dosing cohorts. Essentially, one used a loading dose, the other one didn't. It was given every 4 weeks for 12 weeks, and the patients were followed up through 36 weeks. A lot of information here on the demographics, but what I wanted to hone in on is that patients were about 4 to 5 months post-transplant. The baseline viral load was about 4 log, with the duration of BK viremia about 40 to 50 days. And I will also note, as part of the protocol, that investigators did request that there were no changes to immunosuppression as able. So this is a phase 2 study, so they were interested in adverse effects, and they were thrilled to see that it was overall well tolerated. There were no serious adverse effects related to the drug, no discontinuations due to study drug. Of the drug-related adverse effects, it was mild to moderate, things like nausea, headache, GGT increase. The deaths that were observed were related to COVID-19, so not related to our drug. Since they were looking at 2 different cohorts, they did look at antiviral effects, which were in the blue, and between the cohort that did and did not receive the loading dose, ultimately we saw about similar decreases in viral load reduction, looking at it in a logarithmic fashion. They presented the data in one other way, and while there's a lot going on here, I think it's worth focusing on this. So at week 16 and 36, they evaluated all the each cohort in terms of achieving a viral load lower than the limit of detection. And while overall we were more successful with the MAU868 cohort, we were not achieving this. So I suspect this is going to be one of the areas for the future to determine how to best use this agent. But fortunately, it was safe, it was well tolerated, and from the phase 2 trial, we saw a greater virologic response versus placebo. And our other drug, posoleucel. This is an off-the-shelf allogeneic multivirus-specific T-cell therapy. So essentially how this works is that they take seropositive donors, and these donors have to be seropositive for not just BK, but adenovirus, CMV, JCV, all the viruses that posoleucel they're looking for. They collect the PBMCs and expose that to viral antigens and cytokines so they could see virus-specific T-cell expansion. The potency is confirmed, undergoes cryopreservation, and is ready for treatment. So in this phase 2 study, they included patients at least a month out from transplant with BK viremia. And again, they had 2 different dosing, one by every 14 days, one by every 28 days. From the perspective of study demographics, these patients on average were a little bit over a year post-transplant. Median BK viral load was about 5,000 to 8,000 copies per ml. And the last thing to note here is that patients were able to have a decrease in immunosuppression, but they did note those with a change of greater than 30%, 50%, excuse me, within 30 days of randomization, of which occurred significantly more frequently in placebo arm. So these patients were excluded from the efficacy analysis. But again, we're doing a phase 2 study. So we're looking at safety events first, and it was overall well tolerated. There was one treatment discontinuation, which was deemed not due to the study drug. It was actually due to the patient having tuberculosis. And then in terms of efficacy, they did see a significant improvement or a significant difference in a viral load reduction of 50% or greater in those that received posoleucel every 14 days compared to placebo. And the results, just looking at a 1 log decrease, were promising as well. So they confirmed that it was safe, it was well tolerated, and the greatest effects were seen with more frequent dosing and within a subgroup population of those with baseline viral load of greater than 10,000. Similar to everything else in solid organ transplant, is undergoing phase 3 studies first in HCT, specifically for hemorrhagic cystitis and adenovirus. So I'm going to be very curious to see what comes from those and see how we are able to implement that in solid organ transplant, and if we are. So with that, I'm going to hand it off to my counterpart, Katie.
All right, hello everyone. So I am going to finish out the infectious disease section of the recap. And so the trial that I wanted to talk about today was one of the multi-center Hope in Action studies, and it's specifically looking at infections after kidney transplant from donors with HIV to recipients with HIV. And so this was a multi-center prospective trial that had 25 centers in it, and they compared kidney transplant recipients who had HIV positive donors to those who had HIV negative donors. And so they looked at all infections requiring antimicrobial treatment or hospitalization due to infection, and they captured those to evaluate if there was any differences between groups. They did include opportunistic infections as well. And so let me see, 1 second, I'll need to change the slide here. All right, sorry about that delay. So now I just kind of have up here the demographics for the study. There was one patient in each group going into transplant that did have viremia at time of transplantation. And then they did note that HBV positivity was relatively common between groups, but minimal differences between the two groups at baseline. And so now just kind of looking at infection incidents. So they had very similar incidents of infections between groups, with at least one between 71% for the donor positive group and 69% for the donor negative group. And then similar for infections being related to hospitalization as well as death. And then all those deaths of patients were due to COVID-19. And they did find that there was essentially no difference in infections between groups over time. And then they did want to look at infection incidents over time by time period. So they broke it down into like immediately post-transplant for 6 months, 6 to 12 months, and greater than 12 months. And they did find that over time, there is a decrease in infection incidents in both groups. And then the further from transplant those patients are, the less common infections did occur. And so unsurprisingly, when they did a breakdown of the infection types, they did not break it down by group specifics, as the numbers were too small to really do any comparison statistics. But unsurprisingly, genitourinary infections were the most commonly seen during the trial, with 194 of them occurring, and 66% of them were bacterial. And then kind of next going into viral infections with CMV and BK making up about 60% of all bloodstream infections that occurred during that time. They did notice that there was relatively low numbers of opportunistic infections being AIDS-related, and they did include CMV and CV viremia into those AIDS-defining opportunistic infections. They had a very low incidence of HIV breakthrough, and when they did go back to look at those patients who did have HIV breakthrough, they did have documentation of the chart of the patient missing the medication, like not being delivered, or some miscommunication. So they did not attribute that to necessarily being transplant related. And then another thing is they did do a breakdown of patients who received thymoglobulin induction, and they did see that patients who received thymoglobulin induction did have a lower CD4 count at 1 year post-transplant, but they did not see a difference in infections or hospitalizations due to infections, which I think is something telling for this, of some trying to choose which induction for those living with HIV that are going through transplant, of which you should pick due to the risk of infections, as well as they have a higher risk of rejection. And so it was nice to see that they did not see an increased risk of infection in those patients who received thymoglobulin. All right, so now I'm going to go into diabetes management, diabetes care, which was a really big section from the ATC conference. And so the first one that I wanted to go over was the utilization of non-insulin anti-diabetic agents following pancreas transplant. I thought this was a very interesting section for me. Apologize. So with this study, it was a single center retrospective analysis, and they compared renal function and metabolic parameters of kidney transplant recipients with type 2 diabetes. Oh, I'm so sorry. They compared patients that were kidney or kidney pancreas recipients, and then they had to receive at least 6 months of non-insulin anti-diabetic agents. And so here on the screen, I just have the baseline demographics for the group. I think like the most important is noting what the fasting blood glucose was, with the metabolic parameters at time of initiation being around 121, because they did initiate these non-insulin anti-diabetic agents for pancreas transplant patients that were consistently having fasting blood glucoses greater than 100, or if their A1C was greater than 5.7%. And so this is just kind of a breakdown of what therapies they did utilize. So DPP-4 was the most commonly used, and then they did have a breakdown if it was the initial agent for these pancreas transplant patients, and then they did if it was an add-on or if there was a switch. So DPP-4s were the most commonly used, and then GLP-1s were kind of used less often. And then there were no SGLT2 used, of course. And so really the big thing with this is they did find that patients who were started on these non-insulin anti-diabetic agents, they had a median follow-up of about 41 months with 30 patients. And so they did find that when using these agents, they extended the interval before patients had to start insulin therapy for potentially a failing pancreas graft. And so from time to initiation of the non-insulin diabetic agent to an insulin initiation was about 20 months. And so I think the most important thing is, I think sometimes we do hesitate to start our non-insulin diabetes agents, as insulin is kind of our go-to for these pancreas patients who may have a failing graft. And so maybe thinking about reaching for some of these other agents to maybe prolong the amount of time before we're adding insulin to their regimen to control blood sugar. All right, and then the next one I wanted to look at was some of our GLP-1 agents. And so this one was evaluating the renal benefits of GLP-1s after kidney transplantation. And so this one was the comparison of renal function and metabolic parameters of kidney transplant recipients who had type 2 diabetes that received a GLP-1 for greater than 6 months compared to those who were on alternative anti-hyperglycemic agents. All of these patients were diagnosed with type 2 diabetes prior to transplantation, and then they did start collecting data at about 4 months post-transplant. And then those who received GLP-1s were treated for at least 12 months to be in the GLP-1 treatment group. And so just kind of looking through the baseline demographics, you do see that the time to initiation of the GLP-1 was median of 27 months. And then kind of looking at patients that were in the treatment group, about 63 of them or 80% of them were prescribed insulin at the time of the GLP-1 being initiated. And then we see that dulaglutide was the most commonly used GLP-1 agent at the time. And then I think the most interesting part about this is there are some case reports that GLP-1s can be beneficial with albumin creatinine clearance. So it was nice to see this in like a smaller study. And so with their reference group, they did see a worsening of albumin creatinine at about 6.6 milligrams per gram per year, compared to a decrease in albumin creatinine in those patients who were treated with GLP-1s for at least 12 months of decrease of 4.9 milligram per gram per year. They also did see a decrease in serum creatinine as well. This did not correlate to eGFR, and they did mention that they kind of went back to look through all of their data to kind of comb through and make sure this was accurate, and they don't have a good reason why eGFR was not improved. And another thing with this is they did not detect a difference in weight between groups or A1C. All right, and then I wanted to just kind of follow up with another GLP-1 is the efficacy and safety of GLP-1 RAs in patients with diabetes who underwent kidney transplantation. And this was kind of looking at improvement of post-transplant metabolic outcomes. So this was a single center cohort study that compared kidney transplant recipients who had GLP-1s, and then they had a control group. And all patients were either on insulin or on insulin with an anti-hyperglycemic agent at the time of GLP-1 initiation. And they had a time to initiation of about 5 months. And something that they identified was a statistically significant reduction in daily insulin needs at 6 months in the GLP-1 group. And then they did find that insulin needs did increase in their control group over time. And then there was a significant reduction in weight at 6 months in their GLP-1 group. And then just wanted to talk about an SGLT2 because we can't talk about GLP-1s without talking about the other new anti-diabetic agents. So this one was evaluating the use of SGLT2s in a matched cohort of kidney and liver transplant recipients. And so this was a single center matched cohort study, and their primary outcome was a median change in A1C at 6 months of SGLT2 usage. They had 24 patients in each group, 13 were kidneys and 11 were kidneys and 13 were liver recipients. And then they compared or they matched based on baseline characteristics of on if they were on they were matched on I apologize. They were matched on like A1C and time from transplant. All right, and then going into some of our characteristics. So they were evaluating efficacy. It is important to note that in our SGLT2 group, they did have a higher number of patients on insulin at time of SGLT2 initiation. And then, but they did have a lower number of units at baseline. And then there was no difference in like prednisone dosing. And then little differences in other oral diabetes agents at the time. And so looking at A1C from baseline to 6 months, we do see that the non-SGLT2 group at baseline did have a statistically lower A1C compared to the SGLT2 group, which may have been the reason why the SGLT2 was even initiated in the first place, of continuing to have a higher A1C despite being on insulin or other agents. And then at 6 months, we do not see. Surprisingly, in terms of, since GFR is a big thing that we look at with patients who are being treated with SGLT2s, surprisingly, we did see a drop in the non-SGLT2 GFR at 1 month and 3 months. And then unsurprisingly, the SGLT2 group did have a drop at 1 month and 3 months. And then at 6 months, there was an improvement back to baseline. And then I apologize, I misspoke earlier. They were matched on 2 variables, which was the organ that was transplanted and when they were diagnosed with type 2 diabetes at time of transplant. And then another thing with that previous study is, unsurprisingly, there is about 67% of patients were started on SGLT2s greater than 5 years post-transplant, with only 2 patients being started at 6 to 12 months, which in my experience, we are more hesitant to start patients on SGLT2s within the first year of transplant. So I think this is very similar between the groups. All right, and then finally going into this, so this is the 3rd International Post-Transplant Diabetes Consensus Conference. They provided kind of a recommendation for the treatment of post-transplant diabetes mellitus. So this conference took place in May of 2022, and then they did a consensus conference kind of overview. I think this is if you do have access to the online ATC materials, I think this is a good one if you have a learner or a resident, because it provided a nice pathophysiology of post-transplant diabetes and how immunosuppression kind of accelerates the development of diabetes in our patients. And so they did provide a brief overview of use of SGLT2s and GLP-1s in the transplant population and their impact on renal function as well as place in therapy. And so they also did discuss kind of making changes to immunosuppression, such as belatacept, avoidance of steroids. And then this is their proposed algorithm and the emphasis on kind of including newer anti-diabetes agents post-transplant. So just to kind of go over it, they first go over like post-operative, like hyperglycemia. They recommend, like, if it's very short term, kind of going with insulin. But then if you're outpatient and you're having continued hyperglycemia, they did discuss the use of metformin in your patients who might not have that cardiac risk and have stable renal function. And then, of course, focus on the need for GFR to be greater than 30. And then for patients who had established cardiovascular disease or heart failure, they did recommend the use of SGLT2s or GLP-1s in those patients. And then they did say if you do have a patient who doesn't have stable graft function, they would reach more towards a GLP-1, just because we can use these in hemodialysis and lower creatinine clearance cutoffs compared to an SGLT2, where you do have that drop in the GFR at first that does improve. And then, of course, if you have a patient who can benefit from the weight loss effects of GLP-1s, they recommended that as well. But they did kind of put the caveat, if you have a patient who has unstable graft function or worsening medical conditions that like would contraindicate their usage of our newer agents, they would go for insulin. All right, and then now I'll give it back over to Lauren to talk about just a few extra things that we wanted to discuss.
Awesome. All right. Thank you for that overview of all things cardiovascular disease, Katie. There were two different things that came up during ATC I found particularly compelling. I thought would be great to end the session with. So this first one was from a plenary session, and this was a group that wanted to develop a race-free EGFR equation specifically to kidney transplant recipients. So as we know, estimated GFR, EGFR, very important. We use it in clinical studies as an outcome. We use it as a marker of graft function. So it's important to have an easy way to estimate this and precise way to estimate this, right? So they, oh, sorry, the screen looks a little funny here, but bear with me. So what they did was a multi-center study, and they had two different cohorts. They had a developmental cohort of about 3,600 patients and an external validation cohort of about 12,000 patients. And this was very multi-center, multi-continent, and a lot of these were utilizing patients from other established clinical trials. These patients were about 2 years out from transplants, and a measured GFR was in the mid-50s. So they created a new GFR equation developed with linear regressions with measured GFR as the outcome and recipient variables as the explanatory variables. The equation is as listed, but as you can see, the variables that were kept in the model was creatinine, age, and sex. They compared this to the current GFR equations, which were specifically the MDRD, the CKD-FE 2009, and race-free CKD-FE 2021. So bear with me for this, but I'm going to walk you through how they presented this information. So they evaluated the GFR equations in one of two ways. They looked at number one, P30, which was the proportion of EGFR within 30% of the MGFR, measured GFR, of the four equations. So in the upper left, we have the developmental cohorts, and then we have the remaining cohorts, the 12 of them there. So the left four bars are what you're looking at for the P30. So the MDRD, the CKD-FE, race-free, CKD-FE, and then the kidney recipient specific in blue. And they compared each of these to the measured GFR. And so those bars represent the proportion of EGFR within 30% of the measured. And you're probably scanning across these lines, but the biggest thing that we're seeing is that the pink bar tends to be the lowest. That happens to be the CKD-FE 2021, but the MDRD and race-free kidney recipients seems to be the highest probability, that is. And then the second set of bars, we're evaluating for correct classification per KDIGO stages. And we saw similar trends there in terms of the potential for EGFR to match measured GFR. So the biggest takeaway here that surprisingly the race-free CKD-FE 2021 showed the lowest performance in estimating the EGFR compared to the measured GFR, where the MDRD and the race-free kidney recipient specific GFR seem to be the closest in better performance than the CKD-FE 2009 and the race-free CKD-FE 2021. I think there's a lot of opportunities in the future for this one. The authors note specifically the inclusion of cystatin C. Unfortunately, that just wasn't going to be logistically feasible with the inclusion of these 12,000 patients established from other clinical trials. But that's absolutely an opportunity going forward to see how to even better utilize this information to come up with something that's the most equivalent to what the measured GFR would be. And then a little thoracic spotlight for all my brave thoracic friends that take care of the thoracic patients. Specifically, we're going to be talking about short telomere syndrome. This seems to be all the rage, and it has become a topic that's been discussed at my institution. And so when this came up, I thought, what better than to talk about it? I will be the first to admit this is kind of embarrassing. I had to start at scratch and remind myself what a telomere is. So a telomere is the protective structure that's at the end of a DNA sequence. It's the repetitive DNA sequences that maintains integrity of chromosomal ends. So in short telomere syndrome, it's essentially an accelerated aging syndrome caused by gene mutations, and we see a decrease in telomere lengths. Now, when we have short telomeres, that means we're getting DNA exposure and DNA damage, and then the response to that will be apoptosis and essentially accelerated and aging systems. And then when you have genetically short telomeres, that's accelerated. Now, the threshold for clinically relevant telomere shortening is age and context dependent. And so that's what's seen on the right, is that this presents a little bit differently depending on the age and the degree of telomere length in the context. Now, how this relates to transplant, and especially when we're looking at our adult populations, the pulmonary phenotypes seem to be what show up the most, with the most common being interstitial pulmonary fibrosis, or IPF, which happens to be a common indication for lung transplant. Now, we know that short telomere syndrome has several extrapulmonary manifestations that can very much impact the pre and post lung transplant course. So number one, we know inherent to short telomere syndrome is a T-cell immunodeficiency. So when we throw immunosuppression on top of that, that works through T-cell suppression, we get increased risk for infection. And particularly what we see is increased risk of CMV. A lot of these patients will have bone marrow failure at baseline. They may have cytopenias at baseline. They also may not. But that means when we're using myelosuppressive drugs like Valsite, that can be very challenging to utilize. We also know that there's a lot of hepatic complications, so that needs to be worked up to ensure that patients are appropriate for transplant. So what I have here is what was presented as the Cleveland Clinic Telomere Length Care Plan. It's a bit of a mouthful, but I was very impressed as they acknowledge that these patients are very complex and it takes a village. So this is a snapshot of their village. So this all starts pre-transplant, where they do directed short telomere syndrome testing. So patients with IPF or other pulmonary diseases that have a high likelihood of being associated with short telomere syndrome, they all undergo testing. Patients with confirmed short telomere syndrome undergo genetic counseling. They see ID, and not just ID, short telomere specific ID, and they undergo hematology consult as well as a hepatology workup. And then during listing meeting, they discuss their actual telomere length, because it's broken down by less than the first percentile or the first to 10th. They discuss CMV matching. Now, this is specific to patients that are CMV IgG negative, as if it's possible for that patient to receive a donor from CMV IgG negative as well to prevent a mismatch, that is optimal, but of course that's not always feasible based on the patient. They talk about if this is a patient they'd want to do bronchial arterial revascularization in during the OR, as they know that there's increased risks of dehiscences and airway stenosis in this population. They'll also discuss induction and antibiotic plans. Acutely post-op, there is a large focus on what immunosuppression is safe and achievable, as well as early ID involvement and early initiation of antifungal and antiviral prophylaxis. Outpatient, we start seeing more discussion on immunosuppression and patients, if they can tolerate an antimetabolite, lowering the dose as well as limiting the amount of prednisone use, especially in the case of rejection and tapers. They'll oftentimes use lifelong CMV prophylaxis, and when they start seeing the myelosuppressive challenges, early consideration for letermovir and acyclovir. And then they work closely with their wound team, and they have a specific interventional pulmonology team that they will kind of bring in for these patients that have some challenges with their airway healing, as well as monitoring the clamshell healing. So that's just a snippet of what they do, but I thought it was really admirable. And for a lot of these transplant centers that are just beginning to learn about this, I think it's something that we can utilize to understand how to best treat these patients. So with that, we'll open the floor to questions and see what questions Jamie has received. And I hope that everyone enjoyed the information we shared.
Okay, thank you so much, Lauren and Katie, for recapping such a great conference for us. Keep your questions coming in the chat. I will start off with a question for Lauren with the case studies that you presented. So we have 2 phase 2 studies. Correct me if I'm wrong, but I believe you said that the immunosuppression was not reduced in these studies. They were kept the same.
So the first study, the MAU 868, it was requested to not be reduced, although I couldn't find information to confirm that or not. The second study, they were allowed to reduce as needed, but patients that had an immunosuppression reduction of greater than 50% within 30 days of randomization, they were excluded from the efficacy analysis. So the antiviral graphs, the achieving viral load results, those were entirely excluded. So we do not know how this works with the standard of care.
Interesting. Yeah, and with the reduction with the BK clearance that you see, any sense of how this compares to our standard of care with reduction in immunosuppression?
Oh my gosh, that is such a fantastic question. I didn't get enough information from the phase 2 studies to be able to comment on that. I don't know if they had that prepared quite enough yet, because there wasn't a really good demonstration of starting, peak, and viral load change over time on like a regular basis. But I think that's going to be yet to come, because I believe that both of these are going to absolutely be going forward. And at the very least, we're going to have phase 3 studies of posoleucel, not in BK, but I think that that information can be useful to be determined in general viral response.
Awesome, thank you. And yeah, but it is encouraging to see that seems to be well tolerated, at least the monoclonal antibodies so far. Great. And then a question for Katie. Thank you for the diabetes review. How would you summarize then in your toolbox for post-transplant diabetes when you would, when and for which patients would you pull out the GLP-1 RA or the SGLT2?
Sure. So I can talk about the SGLT2s first. So for me and like my comfort and even just reading some of these studies, I think a lot of times that we shy away from using our SGLT2s within the first year post-transplant because we're really looking for that stable renal function before initiating, particularly with that drop in GFR that we expect to see in most patients. So for me, I definitely want to see some stable renal function. I don't think I would be comfortable starting until we're at least a few months post-transplant, and then also making sure that like stent has already been removed, since those genitourinary tract infections are always a concern with your SGLT2s. I definitely think that another important thing with these SGLT2s that I'm personally interested in is monitoring if you do use cell-free DNA at your institution, monitoring renal function during that SGLT2, or monitoring renal function as well as cell-free DNA during that initiation of SGLT2s. So that way, when you do see that drop in GFR, you're kind of questioning, is it rejection or is it just the SGLT2? And if we have cell-free DNA, we might be able to kind of avoid any panic or any worry in those patients. I think maybe the earliest that I would initiate would be between 3 and 6 months post-transplant in a stable patient, maybe 6 months or later. A big thing for particularly my center, we do have a lot of patients who do need that cardiovascular kind of help from it. And so I always like to look for patients who may have heart failure or before initiating it, so we can kind of like help from 2 standpoints. For GLP-1s, I think that maybe we can be looking into, in several studies that were presented at ATC, looking at GLP-1 initiation a lot earlier post-transplant, because that's another one that we're maybe holding on pulling the trigger a little too late on using them. And so maybe evaluating if you do have a patient who doesn't have that stable renal function, who can tolerate, we've kind of made it through those mycophenolate, nausea, vomiting, diarrhea aspect. And if they can tolerate a GLP-1, I would be a lot more comfortable starting those in like that less than 6 month mark before an SGLT2 if you're concerned about their renal function.
Thank you. And while you were answering that question, another question came in the chat about the SGLT2. So did they find, in the studies that looked at these, did they find an increase in the incidence of UTIs?
Thank you for asking that question, as I completely forgot to mention that. So they, of course, did look at adverse effects that were potentially associated by the SGLT2s. They did find that they did have only 2 UTIs identified that were due to SGLT2s, and they only had 2 patients that had drug discontinuation. So very well tolerated and pretty low number of UTIs were seen.
Thank you. And I think I'll just ask one more just to close our session out. Lauren, thank you for covering a lot of the CMV information that was at the conference. It's just to summarize letermovir, with the study showing non-inferiority compared to Valsite, but with less neutropenia, less leukopenia. You covered that there was, the role for it could include potentially those patients that are neutropenic and leukopenic that still need some prophy and maybe cannot tolerate Valsite. And then maribavir having a role for refractory CMV, but also having that high alert for potential resistance. So maybe checking that CMV resistance panel early on just to make sure you're not starting an agent that's going to be resistant. But I want to ask you about the TCIP, the T-cell immunity panel. Where do you see the role for that currently? When would you send that for a patient?
Amy, that's $1 million question. I have one of the reps that I've been speaking to that serves us here at Kentucky that I pretty frequently pick his brain. I'm going to be honest, in abdominal transplant, at least right now, I don't see a huge role for it because from my perspective, where it makes the most sense is to determine if someone needs to be on secondary prophylaxis after they finish CMV treatment. Most of my patients, they're going to finish CMV treatment, and it's not going to be a complicated CMV. It may not even be a CMV disease, and they're not going to have an increase in immunosuppressive burden. So I generally feel comfortable calling it done with Valsite after I finish the treatment and achieve negative viral load. Where I think it has a lot of utility is secondary prophylaxis in patients with an increase in immunosuppressive burden, say they have concomitant rejection or recent rejection treatment, recent lymphocyte depleting therapy, or say in thoracic transplant, like our lung transplant recipients that just seem to have a more difficult time treating CMV. It takes longer to treat. Their immune system seems to be, for lack of a better word, a little wimpier towards CMV. And that's where I've seen the greatest utility to determine when to continue Valsite versus not, since we do have those significant myelosuppressive effects, which can be compounded by other factors. So that's my thoughts about it right now, but I'm hoping to see more things in the future. I'm going to keep on picking my rep's brain, but maybe we'll see more next year to better elucidate how to better use it.
Thank you, Lauren, for that guidance. Yeah, I think it was interesting data that you presented about how despite the immunity, some patients still became viremic after coming off the prophylaxis. But I think secondary prophylaxis is an area where we may consider this test being sent. So thank you. Well, thank you again, Lauren and Katie, for providing this recap. Thank you all for attending. Spread the word that this will also be available on our YouTube channel as well. Thank you all and have a good afternoon.